a bit of trivia. Next slide. The earliest defibrillation. So what do you think? True, false? True? No, that's not how we came up with KFC. What do you think? True? False? Okay, let's see. Next slide. So it's actually true. So some weird scientist decided to shock these chickens and then lose their heartbeat and then shock them again and get their heartbeat back. So that's how we found out that shocks can actually get back electrical activity in the heart. Next slide. Physicians might get, incensed by this maybe. The surgeon was the first to advocate for chest compressions. What do you think? True? False? False. All right, let's go. Next slide. That's actually true. And chest compressions in 1878 started with Rudolf Bohn. And that was found that it restored circulation in cats. So a lot of studies in cardiopulmonary resuscitation have involved animals, obviously, because it's just very hard to get any kind of studies passed through ethics committees involving humans and around resuscitation. Okay, some additional facts there. Before the chest compression era, we had this, raising the arms and putting that side, So that's how we sort of increased the intrathoracic volume and then compressed it again. So it's sort of similar thingy, may have helped, may not have helped, we don't know. But that's what they used to do. So it's to lift up the hand and put it across the chest. Try to emulate the chest's natural movement. Okay, the next slide is, okay, I don't know whether this is a relevant reference. If you remember this TV series, then maybe from my era. So that's from the, that was shot later, obviously, but the Korean War was in 50, 52 or something like that. What do you think? They had portable defibrillators then?
Yes.
Yes? Yes? Okay, let's see. Next slide. Portable defibrillator was made. Look at this chunk of a machine there that was no more than what 200 pounds it weighed, so that's about 100 kilos in our money. And it was made in 1957. Yes, and those back then the the doctors were cool people with smoke pipes. Excellent, excellent. So next slide. I guess if you wanted more information on the history of the development of CPR techniques, you can go and look it up on these websites. Next slide. So let's just briefly talk about why CPR actually works. What's the theory behind it? What's the mechanics behind it? How does it actually help the patient? And basically, you have to think about what we are doing, what the patient, what's happening to the patient's chest. And there's some gas flows there also sort of tells us about how those relationships between pressure and volume are related, how they work to restore circulation in somebody who's arrested. So if you look at anyone's chest with a scientific eye, if you look at anyone's chest, if you think about it as a cavity and it has a volume, and depending on what you do to that volume, you will either increase or decrease the pressure inside that cavity, right? basically that is the whole what do you call it, mechanism that underpins why CPR works. When you compress down on the chest, you are decreasing the volume, the intrathoracic volume sharply. And as you do that, because of Boyle's law, as the volume drops in a container, the pressure should increase, right? They're inversely related. So when you compress the chest, you increase the pressure, and therefore you get something moves out of the chest. And what is that? Two things will move out of the chest. Yeah, so gas will move out from your lungs, and blood will be ejected from the heart. Okay, and when you recoil, okay, when you go to full recoil position, as the chest now moves back into its former state, as it's doing that, what is happening inside the chest cavity to the pressure, the intrathoracic pressure? It drops, okay? So the volume rises, the pressure drops, and that drop creates a gradient inside the chest that allows blood to return into the chest, into the heart, okay? And also the same thing happens to the air that's outside. There's a gradient created between atmospheric and intrathoracic pressure, and so you have movement of gas. As long as the airway is patent, there's movement of gas back into the lungs, and those two things would neutralize that pressure gradient. Okay. So next slide. If you want to see a nice video of this happening, you're visual people, then I suggest you go on YouTube and you just type something to do with CPR physiology, and there's a number of videos like this one you can see. I haven't linked it. The link is in the other computer, but anyway, so if you were to go into this website, you'll find similar resources that show you those pressure relationships that I was talking about, and how gases move in and out of the lungs, and how blood flows in and out of the chest. Okay. Next slide. So a lot of the recent, or should I say, over the decades, the evidence that has been gathered around CPR physiology have been compiled. This is a bit dated, but the last ILCOR meeting was in 2019 or 2019. And so not much has changed since 2016. In fact, the biggest changes that have come about and have caused real changes to protocols was in 2006 or 2005 ILCOR meeting. And since then, we have seen quite a dramatic change in the focus on chest compressions and sort of not minimalizing, but de-emphasizing breathing for our patients during CPR. And I'll tell you why. So next slide, please. If you don't know what ILCOR is the International Liaison Committee on Resuscitation. And that is basically all of these resuscitation councils around the world gathering and bringing their evidence, having a meeting and deciding on consensus statements. And then, these resuscitation councils are not, they're not, what do you call it? They're not bound by anything that they should follow those guidelines, but they very closely mirror the consensus statements. But they derive their own guidelines. So we very closely follow the Australian-New Zealand Council on Resuscitation, and their guidelines, what you find in most of the public hospitals here in Beijing and also around the Pacific. I don't know, what guideline do you use here? Does anyone know? Make your own guideline? All right. So the last meeting I think was either 2019 or 2020. So there's not much going to be changing in the next 4 years. Next slide. So what has changed? I'll just go through very briefly. Changes in basic life support algorithms and advanced life support. Remember I said there's de-emphasis on breathing now and more emphasis on effective and good quality chest compressions. The reason for that is, remember the pressure gradient you're creating with your chest compression, you are driving the blood out of the chest during the compression, and when you're lifting up, you're allowing the blood to flow back into the chest, right? And when you are breathing for a patient, so you're doing positive pressure ventilation, you're actually undoing that hard work that you've just done. Because now you are increasing the intrathoracic pressure, but it's increasing the volume and then going back to its normal state. So there's no change in pressure that allows for a lower than atmospheric pressure, and so that you don't have that sucking effect anymore on getting the blood back into the heart. And in fact, what you will have when you're positive pressure ventilating is you're actually impeding the blood flow come back into the chest. You're making it harder. First of all, the flow that you are creating, you're establishing, it's sluggish at best. All right. So now you are adding some resistance to it coming back. So obviously you'll be undoing your hard work. So in the past we used to say 30 to 2, yeah, 30 compressions to 2 breaths and go at a rate of 100 compressions per minute. Now we're saying, okay, sorry, we used to say 15 to 2, sorry, my bad, 15 to 2, okay? So that's roughly 12 breaths per minute, if you count all the cycles. Now we've halved that effectively after 2005. We've halved that by going to 30 to 2. So same number of compressions per minute, but 2 breaths for every 30 compressions instead of 15. So you're doing less breathing. The idea behind that is that you want to have better circulation. And we know that somebody's basal metabolic oxygen consumption rate is only about 250 mils per minute at rest. And you've got a big bag, MB bag, which is a 2-liter bag, talking about adults here, yeah? And you're squeezing a good chunk of it in, right? You can expect your tidal volumes to be, definitely more than 250 mils. And what's more is you're giving 100% oxygen. So you really don't have to do so much of the breathing part. In fact, with the chest going up and down with the rescuer doing chest compressions, you are already oscillating a column of gas. Like I said right in the beginning, okay? 2 things move out in and out of the chest. Okay, so the gas moves out. Of course, as long as the airway is patent, gas will flow back in to equalize the pressure that's created, right? The pressure that's created in the chest. So just by you holding 100% oxygen over their face, that increases the oxygen content that's going into their lungs with each upstroke after the chest compression. All right. So in fact, they're already breathing at 100 times per minute. Okay. So we have to kind of it will be difficult for us to switch off and just say, okay, let's not do any breaths at all. I don't think we'll reach that point ever. But we definitely need to not be over-ventilating these patients, because we're definitely going to be affecting the venous return into the chest. All right? So because of that, we have decreased our ratio from 15 to 2 to 30 to 2, meaning that decreased the number of times we're breathing per patient. Our progression to chest compressions is now faster. We don't have to wait. In the past, we used to do, open the airway, then we listen for breathing. Okay, look, listen, and feel for breathing. If they didn't breathe, then we'd give them 2 rescue breaths. This is adults, okay? And up to 5, by the way, up to 5 rescue breaths, and 2 of them should be effective rescue breaths, meaning you see the chest rise and fall. Okay, so this is all taking up some time. Okay, and then after that, you feel for a pulse. And then if you feel for about 6 seconds and you don't feel a pulse, then you jump up and down the chest. All right? And then not only that, but you were told that you do 15 compressions, and then you go back to the airway and you do 2 breaths. This is if you are with the patient, out of the hospital. Right? So you can imagine now how ineffective the chest compressions used to be, and how delayed it used to be before it was started. Okay. So now the BLS protocol says, as soon as you find that they're not breathing, you can start jumping on the chest. You don't have to give them chest breaths. All you have to do is just open the airway first, listen to their breathing. If they're not breathing, start chest compressions. And some of you will say, okay, what about if they have a pulse? Why would you skip that part? If they've got a pulse and then you're jumping up and down on their chest, is something bad to do that? Is that hurting them in any way? Well, maybe. Maybe they might just, wake up and slap you. Get off my chest, yeah? That would be a good thing, right? You'd want that to happen. There's nothing wrong. I mean, you come from a defensible position. I was trying to save your life. Okay, so there's nothing wrong with that. But if you're wasting time trying to give breaths, and then after that you're trying to feel for a pulse, you don't know how long this patient has been without circulation. And so you're just delaying that time. You want that time to be the downtime where there's no confusion to the brain. You want that to be as short as possible. So that means jump onto the chest as quickly as possible. In ALS, again, all the changes that you will find from the 1990s protocols to the early 2005, after the 2005 ILCO meeting, all reflect the same paradigm shift in the de-emphasis on breathing and the emphasis on effective chest compressions. Right? And so in the past, you'd see if you have you're going down the shockable and non-shockable arms of the ALS algorithm. Don't worry, we will run some workshops on ALS, so we will all be familiar with this, hopefully later on in the year. When you're going down the shockable arm of the algorithm, in the past, they used to advocate stepped shocks. So this is what you do. You interrupt your chest compressions, you look at your monitor, and you determine whether it's a shockable or non-shockable rhythm. By the way, can anyone tell me what a shockable rhythm is? Which are the shockable rhythms? And what is non-shockable? Yeah. Anything else that looks different from EF or VT is not shockable. All right? But obviously, to trust your monitor, you need to make sure that you've got good connections and you're reading from the leads and not from something else. Okay? So you need to be familiar with the equipment and make sure you've got the right selection for reading your ECG. So if it was VF or VT, in the past they used to say, charge the defibrillator. Most of them used to be monophasic in the past, so current going in one direction only. Charge the defibrillator to 200 joules, give one shock, look at the monitor again, and if the rhythm was still there, you charge another 200 joules, and you shock again, and then you look at the monitor again, and then if it's still shockable, you charge up to 360 joules, and then you shock the patient, and all of this takes a lot of time, yeah? And what is not happening during this time? There's no compressions happening, and there's no flow of blood, all right? So in fact, we were undoing our hard work. Right? Now, the change in the ALS protocol for the shockable side is once you detect that it's a shockable rhythm, you do CPR, get your shock ready. As soon as your shock is ready, interrupt CPR briefly, quickly shock the patient, go back to doing CPR. One shock only, and use the maximum setting for an adult, no matter what machine you have. So whether you have a biphasic or monophasic, whether it's Chinese, Italian, or Japanese, right? You just look at the selector and turn it all the way, and or if it's got a plus button, hit it till it doesn't change. Okay, so charge to the maximum and give the shock, and step back. Let your team do chest compressions again. It's now established that your chances of recovering a compatible rhythm is better if you have been having good flow or some sort of flow just prior to the shock. Okay, so that is just prior and just after the shock. So that's the reason why we're now not doing stacked shocks anymore. We're doing one shock, CPR immediately before and after, and then we do 2 minutes of CPR before we check the rhythm again. We are not giving we were simplifying the drugs that we're using, and this makes it easier for you to know what sort of drugs to keep in your drug trolley, okay? And it's very simple. If you remember the two A's, adrenaline and amiodarone, those are the two drugs you will most of the time need. And obviously, anything that you need to treat the reversible causes. So like for hyperkalemia, you need the hyperkalemia treatment. For hypokalemia, you need to have some potassium chloride available, all right? So the drugs specific to the treatments. And atropine nowadays is not featured anymore. In the past, they used to say give atropine about 3 or 5 milligrams for asystole or PEA or bradyarrhythmias. There's a shift now to not use atropine anymore, but sometimes we still do. Okay, so minimizing interruptions. So those are the major changes after 2005, and they really haven't changed that much after that. And now the focus is more on how can we improve out of hospital care. So that's where the developed world is headed. They have done massive campaigns and they have increased awareness. Now people can do lane CPR, okay? They're familiar with automated external defibrillators. They're found at almost every block, public, transportation hubs and supermarkets and things. And they'll recognize the sign where there's an AED. If there's someone who has collapsed, they'll get to an AED very quickly and attach it. And the AED will tell you what to do once you've attached the pads on the patient. Once you turn it on, it starts giving instructions. Okay, so that's how the developed countries have managed to improve their out-of-hospital arrest outcomes. We are a little bit far away from that, but what we can start off with is improving our own hospital protocols. So next slide. Okay, so this is just a graphic of everything I just told you. I'm just reinforcing it with some graphics, so hopefully you don't forget this. So every time you see a little blip going up and down there, that's you establishing flow with chest compressions, okay? And so this is where you're starting, and if you halt it for whatever reason, you're giving a breath or you are checking the pulse or whatever, then you're very quickly losing that flow, and you have to work hard to establish it again. Obviously, the more times that you interrupt this chest compression, the less time you're staying at what it seems to be the optimal flow that you can achieve, which is still sluggish, okay? But this is the best that you can achieve artificially, all right? And so we really want to keep our patients for the longest time up here. And that means we really need to minimize our interruptions to the chest compressions. One thing I should emphasize is you never learn how to do CPR or even defibrillation, especially defibrillation, from watching movies, from Grey's Anatomy or wherever, okay? Because they do a lot of things for dramatic effect, and they're not always clinically accurate, all right? So you will see them shocking non-shockable rhythms. You will see them handling the defibrillation pads very unsafely. So pick it up and they'll ask the nurse to put some gel on the things and then they'll go like this. Yeah? Yeah. So you never ever should do that, right? Okay, next slide. So we want to be like this. We want to keep our patient for as long as we can for the 2 minutes that we got to do chest compressions. Keep them up here and then very quickly stop to check the rhythm. Start the resume chest compressions while you get your shock ready. Interrupt, deliver the shock, and then start again. Right? And you know, you can, when you're training your teams on how to do ALS properly, you actually want to measure this time, the time that it takes for them to deliver a shock and restart CPR again. Okay? And it should really be less than 8 seconds. Otherwise, you have to start all over from down here to establish that flow. Okay? Next slide. So we were talking about uninterrupted chest compressions, but some other things we need to focus on. I need to mention here as graphics again, just to reinforce why we need to do what we recommend doing. And two of those things are depth and rate. So important, and it's already been established that you get better outcomes if you compress the chest at about 5 centimeters. This is millimeters, so 5 centimeters or 2 inches in old money, yeah? So if you're too shallow with your compressions, then that drops off your outcomes not so good, right? And if you're too deep, it doesn't improve the chances, but now you start getting more rib fractures, okay? So, you know, better a fractured rib than the patient kicking the bucket. That's what Vinnie Jones said. That's why we do 5 centimeter. It's hard to measure these things, but whoever is running the CPR, they should look at how deep the rescuer is doing chest compressions and tell them to either go deeper or back off a little. Now, the rate is also important. If you're too slow, you're just not generating enough head of pressure to drive circulation. And so, again, outcomes drop off, okay? And if you're too fast, then you're not giving enough time for filling the ventricle before you're emptying it, all right? Remember, the flow is sluggish at best, so it takes time for it to fill the ventricle. So there's a sweet spot somewhere between 100 and 120. And we try to go for 100. And when we teach this to our medical students, we tell them to sing in their mind, in their head, the song. Which song? It's a positive song. Staying Alive, yeah. And not the other one. Another one bites the dust. That's not a very good one to sing. By the way, do not be singing songs when you're doing chest compressions in the real situation, okay? That's just to try and get the rhythm when you're practicing. A lot of people get excited like this, you know, and you're not, you know, you are, first of all, you're going to get tired, and so your chest compressions are not effective. And then obviously you're going too fast, so you're not giving enough time to fill in before you empty. So don't get excited. And whoever is running the CPR, you must look at how your team members are functioning, because this is the most important element. So you need to make sure that they're doing it properly at the right depth and at the right rate. Next slide. Okay, so this is just the protocol for BLS that I've mentioned already. Very simple, doctors ABCD. Very simple to remember this. B is for dangers, so don't just go and start attending to somebody they've collapsed. Be wary of things dangerous to yourself and to the patient. Don't run into the middle of the road without making sure that it's clear. I mean, those obvious things. Disconnect the power source, something that they've been attached to. Check for response. So shake and shout. And if they're not responding, call for help. Because most people will forget to call for help. All right. So remember to do this early. Send for help. Most people have got phones. You can start dialing it, put it on speaker, and go ahead and do the rest of the stuff. And try to communicate. Women should be good at multitasking, so you've got this nailed. Then after that, open their airway. Establish whether they're breathing or not. And if they're not breathing, start chest compressions. That's the progression. And once you attach a defibrillator, that's when you're converting from BLS to ALS, because now you'll have a defibrillator and you have an opportunity to shock a shockable rib. Okay, so next slide. If you want to see how the other countries put up their campaigns for awareness on lay CPR, you can watch this. There are many versions. There's a US version. This is the British Vinnie Jones version. I personally like this one. And it basically tells you to do hands-only CPR or compression-only CPR. And as Vinnie Jones says, you don't kiss the patient because you only kiss your mother on the lips. All right, so there's no mouth-to-mouth anymore for lay rescuer CPR. Obviously, in the hospital, you've got a bag and an ambu bag and a mask. You can kiss them with oxygen. Yeah. Okay, next. So this is the protocol that we follow in most public hospitals here. In the past, I said this used to be stacked shocks. So now this is only one shock. You go to VF, VT. And every cycle is 2 minutes of CPR. 2 minutes of CPR and then reassess the rhythm. If there's a non-shockable rhythm, then you just do 2 minutes of CPR and then reassess. So it's very simple. When to give the adrenaline? The guidelines say 3 to 5 minutes, keep repeating. What the NSCORE guidelines say is for the non-shockable side, the very first cycle you give adrenaline, and every alternate cycle after that give adrenaline 1 milligram when added. Follow it with a little bolus of fluid, otherwise it's just 1 ml is stuck over here in the line itself, hasn't even reached the vein. And if you're starting off with the shockable side, then you give the shock and adrenaline on the next cycle and then on every other cycle. So adrenaline on the first, third, fifth, seventh. Hopefully you don't go down to 9 or 10. And then if you're on this side, you start on this side, then you start off with the second cycle, you give adrenaline, fourth cycle. So even numbers, odd numbers. And after the third shock, you give amiodarone. Yeah. Next slide. So there's a lot of research being done. Like I said, not much has changed after 2005 and 2006. Those were the major changes to the algorithms as we know them today. But now there's a lot of, move towards strengthening pre-hospital care. And another thing that that has been done in the past is targeted temperature management, trying to keep them cool. There's a lot of evidence supporting keeping the patients cool, and that has better neurological outcomes after arrest. Probably the only sort of scenario where hypothermic management helps with neurological outcomes. Doesn't translate well to all other types of scenarios. And even then, there's there's mixed evidence on that. But, yeah. Not enough strong evidence suggesting extracorporeal CPR. Don't worry, it's not available to us, so we don't have to worry about that. And not enough evidence yet for CPR-related products. And I mentioned some of these. I'll mention some of these products and how they, are making use of the mechanics of CPR that we've already talked about. Okay, that pressure gradient and things like that. So next slide. This is just the consensus statement. If you have time to read a 350-page document, I would go for the executive summary, which is only 100 pages. So really summarizes most of what I've just said. Okay. Next slide. So this is what the developed countries are now focusing on. In the last ILCO meeting, they were talking about, well, why don't we try to improve our out-of-hospital arrests by providing a service where we can help the person on the line, guide them on how to do proper CPR. Okay. So now you do dial 911. So when Michael Jackson had his event, eventually when they called 911, even though the doctor was there, they were directing them what to do before the ambulance people came. All right. The fellow was still on his bed. Those nice soft beds. So when you're compressing on him, he's moving down, not having much change in the intrathoracic pressure there. So the first thing they instructed the security person to do and the doctor to do was put Michael Jackson on the floor, so he's against the hard surface, and to do more effective chest compressions. So we might practice this after I show you, and let's see if someone can direct us how to do good chest compressions. Okay, next slide. There's good evidence for that device there. I'm not advocating for that, but I'm just saying that's a what do you call it? Active chest compression device. Right? It's a suction cup that so obviously not good for hairy chests, but suction cup that's attaches to the patient's sternum, and you can lift and push and lift and push. And that way you're getting bigger changes in volume and bigger changes in pressure inside the chest. It's got a little gauge on the top there that you can look at and see if you're doing it effectively. Obviously the rate drops off with this, and but you can still maintain good perfusion with 80 compressions per minute. So it's less than 100, but then you're getting better movement of the chest, better displacement. There's a lot of training tools available. I've just brought one that we use for our medical students and postgrads. Hopefully we get to turn that on and see. Hopefully it's still charged. I haven't picked that up in a long time. But simulation-based training is really the way to go for ALS. If you haven't been managing patients who are critically ill, then you're not going to be coming across this situation very often. And so after a few years, the practice kind of falls off and you forget what you need to be doing. And when there is an emergency, then you kind of have to jog your memory, and you're kind of hesitant to participate properly. Okay? So let me just say from the outset, if you're ever hesitating to participate in a chest compression, in a CPR, or hesitant to be the one initiating it, don't feel like that. All right? Patients already lost their pulse. They have no perfusion. You can't make a bad situation worse here. Okay? So even if you think you're doing something wrong, the fact that you're going to do something is better than not doing anything. All right? So never ever feel that you're going, I'm not feeling comfortable doing this. The fact of the matter is, if you're the only one there, then that you're the best chance for that patient. So, the next slide. I just wanted to show you the graphical representation of what happens inside the chest with standard CPR and with one of these devices. Okay, this is the active compression device, and basically you have quite a bit of extra pressure generated inside the chest, negative pressure that sucks the blood back in the heart, into the heart. Yeah. And then you are loading, unloading that during the next compression. So it's theoretically a better way to go about things. So shave all your patients. Next slide. This shows you 3 graphs. Standard CPR, intrathoracic pressure, really little blips there, but you still are able to, you still are able to get some aortic pressure generated. Yeah? Right atrial, and that's as long as your depth is good. With the active compression device and impedance thoracic device, and this is impedance thoracic device is basically a little connection you put on the ambu bag that will allow the breath to be given and allow the patient to exhale. But once the chest is coming into recoil, it blocks off a valve. So air doesn't rush, or gas from your ambu bag doesn't rush in to neutralize that pressure. Instead, it gives more time for the blood to get sucked in, right? So it'll hold a bit of a negative pressure there, that valve closing off, and that improves the amount of blood, the intrathoracic pressures that are generated, and the aortic pressures as well as the right atrial pressures. If you combine that with the intrathoracic pressure regulator, and that's another device that you add to your ambu bag, between the ambu bag and the patient's endotracheal tube, there's a little port that creates suction, and you can regulate that so that you are generating about -10 millimeters of mercury, and it'll still allow you to deliver breaths and things. But now it's really holding the intrathoracic pressure in a negative, sort of lower than atmospheric pressure state for longer. And you can see that that's almost off scale there. Way better. So this is where we're headed with trying to improve the mechanics of chest compressions. And there'll be a lot of products that will be advertised, and people will try to get us to utilize them. Again, I've said before, the evidence is not yet strongly supportive of using these things. Next. Yeah, basically the same thing. Next slide. Okay, do we have time? What's the time?
1 minute.
1 minute. All right, maybe then I'll just show you. Rahul, we need to just. I'm planning to hold the ALS workshops later in the year. Hopefully, by that time we get our mannequins that we can practice on. Otherwise, we have to borrow these battered ones from the school. So this is the typical CPR dummy. Let me just go through basic life support. All right. Patient has collapsed. What's the first thing I should do? Dangers. Okay, so make sure that there's no danger to the patient and myself. And then response, shaking shot. And then they're not responding. Call for help. So dial what? What number should we dial? We dial. Put it on the speaker. Okay. And what's the next thing now? So we ask for help. What's the next thing? Airway. So we open the airway like this. All right. What's next? Breathing. So we listen and feel for breathing. If there's no breathing, what do we do? Okay. So let's put into practice everything we've talked about. Rate, depth, full recoil, right? And uninterrupted. So we'll just do it for a short while. I'll get tired. So
How do you hold your hand? It really doesn't matter. Okay, as long as you're able to transmit the force right onto the sternum, right, and the lower half of the chest, then you'll be fine. Otherwise, if you're to one side or the other, you will break some ribs. In that case, just shift a little bit towards the center. Okay, that's fine. Better a broken rib than the patient kicking the bucket. So lock your elbows. Try to get your weight above the patient's chest. All right. If they're on the floor, even better. Then you can just kneel beside them. All right. So lock. Stay in the line. Stay in the line. Never do this again. Just show you. So if you're doing this, right, then it's not good. You'll get tired very quickly, and you're not using the big muscle bulk of your back to do all the work. This muscle is, longer lasting than these ones. All right, this Kathy might agree with me. So you'll have a sore back. If you do, that means you've been doing good CPR. If your triceps are sore, then you haven't been doing good quality chest compressions. Okay, so this way. In the past, they used to say, go from the bottom, feel the zip sternum, then put one finger, two finger breaths, and I mean, you're wasting time doing that, right? So just eyeball the chest, go to the sternum and the lower half, and just do this. All right? Don't be too fast. Remember what rate are we going for? Don't be shallow. Don't be the lazy person just staying on the chest like this, not allowing it to recoil. All right. So, and don't jump around. Okay. All right. So this, we might laugh now, but this is the most important thing that